domain 7, NEL, serapondin, and many other tissue and serological biomarkers. There has been similar change in the treatment also. We knew of steroids, standard dose and high dose, Kogan et al., Donadio et al., Cameron et al., and then came the era of alkylating agents, Ponticelli's, chlorambucil, and then cyclophosphamide, modified Ponticelli. Then came calcineurin inhibitors, cyclosporin, and tacrolimus. Then finally comes in the recent time, rituximab, in the time of Gem-Ritux, versus conservative treatment, then Ritux versus cyclosporin, and then Starman, and now we again have latest obinutuzumab. To take us through this journey, I invite Dr. BhadranBose. Dr. BhadranBose is an Indian working in Australia, trained MBBS in India, then in UK, and then Australia, and then Canada. He has wide interest in glomerular disease, especially membranous. Over to you. Tell us, Dr. Bhadran, what are the recent developments in field of membranous? Thank you.
Thanks very much for that. I think you made my work a little bit easy. As you already mentioned, I'm going to go through not just the update, but I would like to go through the journey of membranous nephropathy over the years, and then we'll talk about the latest update. So as far as my disclosure is concerned, I've got none relevant to this presentations. And we'll talk a little bit about epidemiology, clinical features, pathogenesis, and as Sir mentioned, I will touch about the new biomarkers, and we'll talk about treatment and some future studies, which I do have some special interest myself. As far as epidemiology is concerned, membranous nephropathy is the most common cause of primary nephrotic syndrome in adults. It accounts for about 20 to 30% of patients with primary nephrotic syndrome. More common in white men, and it's common in the 4th and 5th decade of life. It's the second or third leading cause of kidney failure among adults with primary GN. The first leading cause is IgA nephropathy, and we have second can be either contested between membranous nephropathy or FSGS. Like any disease, it can be primary or secondary, and as a clinician, it's our job to identify whether it's primary or secondary as early as possible. As far as clinical features concerned, most patients present with nephrotic syndrome. However, we do have a majority of patients who can present with non-nephrotic syndrome as well. About 30 to 50% of patients can have non-nephrotic range proteinuria. About 40 to 50% of patients can have hematuria at the time of presentation. And hypertension is not unheard of in patients with primary membranous nephropathy. And about 20 to 40% of the patients can have renal insufficiency. So if a patients come with non-nephrotic range proteinuria, that doesn't mean that they don't have membranous nephropathy. They still could have membranous nephropathy. As far as cause for secondary membranous nephropathy, there is a whole heap of causes which can cause secondary membranous nephropathy. Immunological cause, neoplasms, mainly solid organ tumors, but there are rare instances where hematological malignancy can be associated with membranous nephropathy. Infections, including COVID-19, can cause membranous nephropathy. There are a long list of medications which can cause membranous nephropathy. Now, how do we differentiate primary versus secondary? A good history is very, very important. So the time we spend with the patients, getting a good history, trying to go through some immunological history, trying to go through some drug history is very, very important. And obviously doing relevant serology. If you're suspecting lupus in a young girl, obviously look for lupus serology. And there are some biopsy features which can help us differentiate primary versus secondary membranous. And as Sir mentioned before, biomarkers, and every time I go for a US conference, there's a new biomarker being described over there, and PLA2 antibodies being one of the landmark biomarker in membranous nephropathy. As far as the biopsy feature is concerned, as you know, that the primary antigen in membranous nephropathy is present in the subepithelial space. So if you have a disturbance elsewhere in your glomeruli, then you think it's probably going to be a secondary membranous nephropathy. For example, if you have mesangial hypercellularity, then it's unlikely to be primary membranous nephropathy. Or if you have electron dense deposit in the mesangium, subendothelial, or tubular basement membrane, you'd think of a lupus membranous rather than a primary membranous nephropathy. Tubular reticular inclusion body should not be seen in patients with primary membranous, and you think of a lupus. Similarly, intense C1q staining, you can see in patients with lupus, but not in patients with primary membranous. And hepatitis antigens can be stained in the tissue, and crescents we don't tend to see crescents in patients with primary membranous nephropathy. As far as biopsy is concerned, I'm not going to be showing you a lot of colorful pictures, but this, I'm sure everybody's seen this in the biopsy meeting. There's a silver stain of a patient with membranous nephropathy. You can see the GBM being thickened, and you can also see the spikes in this light microscopy. As far as immunofluorescence is concerned, there's a granular capillary wall staining of immunoglobulins and complements, and IgG is the most commonly present, and if you have IgG4 subclass, it has to be a primary membranous nephropathy. As far as electron microscopy is concerned, patients lose their porocyte effacement, and there are symmetrical subepithelial deposits along the GBM. Now, talking about antigens, as Sir mentioned about the Hayman nephritis, which was initially described in 1959, between 1959 to 2009, we had a very dry period in membranous nephropathy. However, since 2009 till now, we have got a lot of new biomarkers being identified. The first one being the M-type PLA2R antibody, which I'll talk a little bit more in detail, and the thrombosporin type 7A. Then recently we have the exhaustin, NEL1, SEMA3B, PCDH, and the list goes on. In membranous nephropathy, one of the landmark publications, I would say, is this one in 2009. There are multiple landmark publications, but this is one of them, especially for diagnosis and differentiating primary versus secondary membranous nephropathy. So this was done by Dr. Laurie Beck's group from the UK. They initially identified this antibody against PLA2R receptor using Western blot, and subsequent to that, there has been ELISA test being done, which has got more specificity and sensitivity compared to the Western blot. PLA2R antibody is a major, PLA2R receptor is a major target porocyte antigen involved in adults with autoimmune idiopathic membranous nephropathy. And initial studies show that 70% positivity rate in Caucasians and African Americans. And the East Asians, the positivity rate is about 44 to 54%. Specificity of PLA2R antibody is somewhere between 70 to 100%. And I'm sure most of you have seen this sort of slide before when we talk about PLA2R antibody. Imagine if we have a test like this when we manage any patient. You can see the antibody titer going down even before patient attains clinical remission, and patients, the titer goes up even before patient has a clinical relapse. So if we can have this sort of test in ANCA vasculitis or any other condition or IgA nephropathy, I think we'll be very gifted, and we probably can predict how our patient is going to do. So I think we are very grateful for PLA2R antibody that we can actually test it and identify how the disease course of the patient is going to be in future. Talking about PLA2R antibody, it's very important to talk about epitope spreading. What is epitope spreading? It's an immunological phenomenon whereby an antibody or a cellular response to a given antigen may extend from one location of the antigen to involve other region of the same antigen or adjacent antigen. What does that mean in simple English? This is PLA2R receptor, and it's an antigen. The antigens have different epitopes, and the initial epitope is a cis-R in patients with PLA2R antibody, which is antigenic. And during the course of the patient resistant to the disease, what happens is the antigenicity moves from one epitope to a different epitope, and that's what is called as epitope spreading. And what's the relevance of epitope spreading in membranous nephropathy is, if a patient has epitope spreading, the chance of them responding to your agent is very, very small, and you've got to be very, very aggressive in managing these patients. At the moment, it's not easily available in testing epitope spreading. I'm sure there are clinicians or researchers across the globe who are working on it. Thrombosporin type 1 is another antigen being identified in patients with membranous nephropathy. It is identified in 5% of the patients who are PLA2R negative, and it's associated in about 2 to 5% of patients with idiopathic membranous nephropathy. And there is an association of cancer in this sort of antibodies. Researchers are still looking to see if we can identify other antigens in patients who are PLA2R negative using laser microdissection and tandem mass spectrometry. So far, we've got they've got multiple lists and a long list, and some of them I've just summarized in this slide. We have exhaustin 1 and 2, NEL1, PCDH7, and SEMA3P. The exhaustin 1 and 2 has been associated with patients with autoimmune disease. And NEL1 has been noted in patients with primary membranous nephropathy or malignancies. PCDH7 has been noted in patients with prostate cancer, and SEMA3B has been observed in patients with family history of membranous nephropathy. So when you see a patient, it's very important before we start treatment, we need to work out how bad the prognosis is going to be. And if the patient is a male patient above the age of 60 and hypertension at the time of presentation with renal insufficiency and a biopsy showing secondary focal segmental glomerulosclerosis and interstitial fibrosis, then the patient's prognosis is going to be very poor, and you've got to be very aggressive. Along with that, if the patient has very high PLA2R antibody, various literatures quoted numbers of 150 or 175 at the time of presentation. If the patient has those numbers, then the patient is going to be having very poor prognosis. So you've got to be very aggressive with these patients in treating them with immunosuppressive agents. Now, as far as treatment of membranous nephropathy is concerned, I like to have this holistic picture when I manage any patient, live alone membranous nephropathy is, when do we start treatment, what do you aim for, and what agent do we use? And the question about in membranous nephropathy is, when do you start treatment and why do we have to start treatment? So this is a study done by Dr. Catron, my mentor from Canada, who actually looked at degree of proteinuria and looked at GFR slope over the years. In patients with membranous nephropathy, if they have a proteinuria of more than 5 grams, they would lose their GFR every year. So if a patient with primary membranous nephropathy has subnephrotic range proteinuria, we don't need to subject them to immunosuppressive therapy. So we can reserve immunosuppressive therapy only patient has nephrotic range proteinuria. And you can see in the same study, they noticed that patient with IgA nephropathy, if they have proteinuria of more than 1 gram, that's when they will lose their GFR. So henceforth, most of the trials in IgA nephropathy focus on the number 1 gram and try to bring the proteinuria below 1 gram. Now, going back to the treatment, we have this approach in non-immunological treatment. Then we talk about immunotherapy. Then we managing the complications of nephrotic syndrome and the managing the complications of things which we have done to our patients, that is managing the complications and side effects of immunosuppressive therapy. I won't talk about the last two, but I'll talk about the first two. As far as the non-immunological treatment is concerned, protein intake is concerned. As far as protein intake is concerned, KDIGO recommends 0.8 to 1 gram per kilogram per day, plus urinary protein loss. Salt restriction is very, very key, and as nephrologists, when we deal with patients with chronic kidney disease, I think our mantra is to make sure that we advise our patients to have salt restriction, whatever the cause of the kidney disease is. ACE and ARB, as much as tolerated, as anti-proliferative and anti-inflammatory agents. Diuretics as needed, and statins as indicated and based on risk factors. As far as immunotherapy is concerned, we have evolved a lot over the years, and initially they looked at steroid monotherapy, then they looked at cytotoxics such as chlorambucil, then cyclophosphamide came into the picture, and there's a lot of interest from North America looking at calcineurin inhibitors, and from India we've had a couple of publications looking at mycophenolate mofetil, and as Sir mentioned, rituximab, which is the flavor of the last decade in kidney disease, and so with membranous nephropathy as well. And there are some small studies which looked at ACTH. So I'll try to go all of these agents one by one. As far as steroid monotherapy is concerned, in the 70s and 80s, there were a randomized control trial where looked at steroid monotherapy, and you can take my word, steroid monotherapy does not work in patients with primary membranous nephropathy. It might work in patients with pure class 5 lupus nephritis, but in patients with primary membranous nephropathy, steroid monotherapy is a big no-go zone. Dr. Claudio Ponticelli from Italy, he came up with this Ponticelli protocol where he gives cyclical corticosteroids with chlorambucil. So he had 81 patients with primary membranous nephropathy. 42 of them he treated with this cyclical protocol of corticosteroids with chlorambucil, and 39 patients received no immunosuppressive therapy. I got to make a point that at that time, standard of care did not involve ACE or ARB. And a 10-year follow-up, in a 10-year follow-up, they noticed that the remission rates, renal failure rate, death was significantly in favor of patients who received the combination of corticosteroids and chlorambucil. However, there was a lot of concerns about using chlorambucil, mainly the risk of secondary malignancies. So Dr. Jha's group from PGI Chandigarh, they did a study where they used cyclophosphamide instead of chlorambucil. So similar to what Dr. Ponticelli did, in this study, Dr. Jha and group, in 46 patients, they gave a combination of corticosteroids and cyclophosphamide in cyclical manner, and 47 patients did not receive any immunosuppression. In a 10-year follow-up, they showed that the proteinuria and eGFR was again in favor of patients who received the cyclical protocol compared to patients who did not receive any immunosuppressive treatment. Now, there are a lot of clinicians that still wanted to believe chlorambucil is still the way to go. So there was one small head-to-head study which compared the chlorambucil-based protocol against cyclophosphamide-based protocol, and they noticed that there was the efficacy was more in favor of cyclophosphamide, and the side effects were more in patients who received chlorambucil. Henceforth, the combination of corticosteroids and cyclophosphamide became the standard of care in managing patients with membranous nephropathy. However, there were clinicians and researchers who were not very keen to use cyclophosphamide and high-dose corticosteroids in a non-proliferative condition. So they were looking at calcineurin inhibitors. So Dr. Catron group, they looked initially at cyclosporin, and the last decade, different groups have been looking into tacrolimus as well. In this slide, I've actually summarized some of the key studies which have looked at CNIs, and you can see the remission rate at 24 months is somewhere between 24 to 80%. This is total remission, complete and partial remission. But in CNI studies, we never have had a 10-year follow-up, which was similar to what Dr. Pondicherry and Dr. Jha had done. So, but still slightly less toxic, so hence a lot of clinicians were still using CNI. But one of the drawbacks of using CNIs is the relapse rate. So if you stop CNIs, 50% of the patients would have relapse. So henceforth, there's a little bit of anxiety about using CNI in patients with membranous nephropathy. Is there a head-to-head study comparing cytotoxic agents versus CNI? Yes, there was one study from Dr. Peter Matheson's group from the UK, where they had 3 arms in the study. One arm received patients with corticosteroids and chlorambucil. Second arm patient received CNI, and third patient did not receive any immunosuppression. In a 3-year follow-up, the combination of combination of corticosteroids and chlorambucil did very well compared to CNI and no immunosuppression. However, one of the biggest drawbacks of this study was a significant dropout rate at 3 years. Again, from PGI Chandigarh, there was a study where they looked at a combination of cyclophosphamide and corticosteroids and comparing with tacrolimus with glucocorticoid. And you can see at 24 months, the remission rates, the complete and partial remission rates were in favor of using cyclophosphamide and corticosteroids. Now, MMF, slightly less toxic compared to cyclophosphamide. Again, from Chandigarh, they've done a study where they looked at the combination of MMF with steroids, comparing with combination of corticosteroids and cyclophosphamide. And at 12-month mark, the remission rates were similar, or the proteinuria rate was similar in both arms. However, it was a small study with a short follow-up period, hence we couldn't make any conclusion. Now, rituximab is, as I've said before, it's become a flavor of as far as kidney disease is concerned. Initially, it was case reports and case series and observational studies in patients with resistant membranous nephropathy. However, in the last decade, there has been a few randomized controlled trials looking at rituximab as first-line therapy. The first study is a French study called the GEMRITEX study, where they had 38 patients who received no immunosuppression, ACE or ARB, diuretics and statins as needed. And in the intervention arm, patient received 2 doses of rituximab. Along with that, patient received ACE or ARB, diuretics and statin as needed. And at 6 months mark, there was no difference in the remission rate, whether it's complete or partial remission. There was no difference between both arms. However, at 17-month follow-up period, the remission rate was far superior in the patients who received rituximab compared to the one who did not receive rituximab. For the clinicians who are using rituximab, this study is gives us a story that if you're using rituximab, you got to wait at least 6 months, if not longer, to see any sort of clinical response or even serology response. MENTO study, which I'm sure everybody has heard and has read about, it's again a North American study where they looked at patients with primary membranous nephropathy with a proteinuria of more than 5 grams in a day, the creatinine clearance of more than 40 mils per minute. 65 patients received rituximab, so on day 1 and 15, 2 doses, and again at 6 months, based on remission, patient received further 2 doses of rituximab. In the control arm, cyclosporin was given for 6 months initially, and depending upon response, further 3 to 6 months were given. And at 24 months, you could see that the remission rate was far superior in the rituximab arm, up to 60%, and only 20% in the cyclosporin arm. None of the patients in the cyclosporin arm achieved complete remission. The 20% were mainly partial remission, so there was no complete remission in the cyclosporin arm. One of the drawbacks of MENTO trial, which I personally feel is the control arm. And as we know from historical studies and what I've just shared with you recently, that compared to a combination of corticosteroids and cyclophosphamide, cyclosporin is an inferior agent as far as efficacy is concerned. So the control arm itself was a weaker control arm, and the protocol they used for CNI was not what we normally use. So if we have a patient who we treat with cyclosporin and the patient achieves a remission at, let's say, 6 months or 12 months, we're not going to stop that agent. We're going to continue, whereas they actually stopped it by 12 months. So there's no wonder there was no patient with complete remission at 24 months. There was no difference in the adverse events between rituximab and cyclosporin, but however, there were some clinicians who have started changed practice moving on to rituximab. There's another study which looked at rituximab called the Starman study. It's a European study where they had 43 patients who were treated with a combination of cyclophosphamide with corticosteroids, and 43 patients were treated with a sequential treatment with tacrolimus and rituximab. So in the intervention arm, patient received 6 months of tacrolimus, and at 6 months mark, the dose was slowly tapered. At 9 months, tacrolimus was completely stopped, and only 1 dose of rituximab was given at 6 months. And you can see in this study, the complete or partial remission rate was about 83.7% in the patients who received combination of cyclophosphamide and prednisone. This is the highest remission rate ever been noted in any membranous nephropathy trial. And in the patients who received the sequential treatment with tacrolimus and rituximab, only 58% of patients had complete or partial remission. And if you look at complete remission, 60% of the patients who received this combination of methylpred and cyclophosphamide attained complete remission, and only 26% of the patients who received tacrolimus and rituximab achieved complete remission. There was no difference in the adverse events. Now, is there any study which will look at rituximab versus a combination of corticosteroids and cyclophosphamide? There's one study called the ReCyclo study. Again, it's an Italian study. The patients received 2 doses of rituximab in one arm, and the other arm patients received cyclical corticosteroids with cyclophosphamide. And at 36 months mark, there was no difference in the complete or partial remission rate. However, it is only a pilot study and underpowered, hence we can't draw any conclusion. I would like to share this study. This is not a randomized controlled trial. This is by Dr. Meryl Wallman from NIH. She used a hybrid protocol of rituximab and CNI. So she gives 2 doses of rituximab upfront, and 6 months she gives further 2 doses of rituximab. Along with that, she gives a total of 9 months of cyclosporin. And she's compared the results of her study with the historical study. Keep in mind, it's not a randomized controlled trial. It's a single-arm pilot study. She reports 54% complete remission rate at 24 months, which is far more superior compared to the other investigational drugs. ACTH, we don't have any large studies to comment about ACTH, so I won't talk much about it. But I would like to touch very quickly about the KDIGO guidelines. KDIGO recommends that we should risk stratify our patients based on serology and also based on clinical presentation. And we should use our agent of choice based on risk stratification. So patients with very high risk of progression, we should use combination of cyclophosphamide and glucocorticoid. And in patients who have moderate risk, we should use rituximab, CNI with glucocorticoid, and high risk, either rituximab or cyclophosphamide with glucocorticoid. Now, moving on to future trials and ongoing trials, there is a trial called Majesty trial, which is looking at obinutuzumab versus tacrolimus. It's an industry-sponsored trial. Again, they're using control arm of tacrolimus, which is far more inferior in efficacy compared to corticosteroids and cyclophosphamide. There's another study which is using an investigational drug called LNP023, comparing against rituximab. There's a study called Reboot study, which is comparing belimumab versus rituximab. And there's a study comparing a combination of rituximab with cyclosporin against rituximab alone. The last study which I want to talk about is the REMIT trial, which is a trial which my group is working on, and I'm one of the chief investigators, and hopefully start the study middle of this year. It's Remission Membranous Nephropathy International Trial. We're going to look at patients with primary membranous nephropathy with an EGF of more than 40. We're going to randomize 1-to-1. Minimization variables include degree of proteinuria, PLA2R antibody status, and relapsing and remission status. Patients in the intervention arm will receive 4 doses of obinutuzumab, which is a superior B-cell depleting agent, and the control arm patient will receive combination of corticosteroids and cyclophosphamide. And the primary outcome is looking at complete remission at 24 months. When the study has been completed, it will be the largest study in patients with membranous nephropathy. To summarize, it's very important to differentiate primary versus secondary membranous nephropathy as early as possible. Treatment should initially include non-immunosuppressive therapy. A choice of immunosuppressive agent should be based on patient's risk stratification. Role of PLA2 antibody is very, very important, not only for diagnosis, but also to guide treatment. And there are new agents in Horizon. We've got to look out for that. And I would like to thank everybody for your attention. Thank you.
Thank you, Dr. Bhadran, for excellently discussing the latest updates on the management of membranous. Before I pass on the mic to my co-chairs, I have a question. How would you like to treat a patient who relapses after a treatment, either with a modified Ponticilli or Mantor trial? And second, a comment from our institute in PGI. Dr. Ramachandran also had a published earlier study, C19 targeted low dose rituximab. Do you have a comment on that?
Dr. Raj is a good friend of mine, Doctor. Yes, I think I'll take your first question about how do we manage patients who are relapsing, or if your question is about resistant disease, Doctor, or relapsing disease?
Relapse after treatment with Ponticilli.
So it depends upon what was your initial agent. So if your initial agent was a combination of corticosteroids and cyclophosphamide, and the patient had a very good response to that, and then they relapsed, and if they have not received lifetime maximum dose of cyclophosphamide, I would actually suggest using it again, corticosteroids and cyclophosphamide. However, in the past, if the patient had a lot of adverse events with combination of corticosteroids and cyclophosphamide, then I think rituximab is the way to go.
Are you going to give a repeat course of modified Ponticelli regimen in that case?
If they responded very well and they have not had lifetime maximum dose of cyclophosphamide, i.e. more than 25 grams, then I would consider giving them modified Ponticelli again.
Thank you, sir, for that excellent update. I've got a clinical question. Supposing a 65-year-old man diagnosed with membranous nephropathy, serology is negative, but tissue is positive PLA2R. What will be your initial management? Do we straightway think of rituximab or prednisolone modified Ponticelli?
I would go by as per KDIGO. So as per KDIGO, if the patient's got a very high risk of progression, then I would definitely use combination of corticosteroids and cyclophosphamide. Again, I'm talking about different population where I practice compared to what you practice, doctor. So 65 in Australia is relatively young. So and I would use combination of cyclophosphamide with corticosteroids. However, if it's 65, but very frail 65, probably use rituximab in those patients.
Before I open up the question to the audience, I have a very short question. Is there any headway made in assessing the epitopes? Because that is very important in addition to the other prognostic indicators which we all look into. But is there any advance made in the analysis of the epitopes? So that will really help us in trying to see who are the people who are going to be progressing.
Yeah. As far as I know, doctor, there's no clinical availability of epitope spreading, how to test it commercially. But I know it's there in the research world, but not in clinical practice yet.
Thank you. Are there any questions from the audience?
Hello. In transplant situation, how will you differentiate de novo from recurrence? Whether PLA2 antibody will help there, and how will you manage?
I will put a disclosure, doctor. I don't do acute transplant, but I can tell you based on my observational experience that I would treat patients similar to what I do with native kidney, but obviously we don't want to use cyclophosphamide, so I would probably use rituximab if that patient has a relapse of the disease. Now, whether it's a de novo disease or whether it is a recurrence of the disease, obviously it depends upon if we have access to the biopsy and the initial diagnosis before the patient started dialysis or had a transplant. That will be the most important questions. But post-transplant setting, I worked with Dr. Catron, and he uses rituximab for patients with recurrent disease post-transplant.
Yeah. You said the response to rituximab is a little delayed. So what is the reasonable time period do you want to wait after giving rituximab?
So if you look at the GEM-RITUX study, it says at 7 months when they start seeing the PLA2R antibody coming down. So if you're going to give rituximab, you've got to wait for at least 6 months, if not longer. At 7-month mark, you would start to see the PLA2R antibody coming down, and only at 8 or 9 months time, you would start to see that the proteinuria is coming down. So at least wait for 6 months, if not a little bit longer, before you can start to see a difference in PLA2R antibody, and a little bit longer to see any clinical remission.
Dr. Girish, you want to ask something?
Any partial response in proteinuria at 3 months, will give you any idea about that?
I know that there are people looking at partial remission at 3 months and redosing it. I know, as Dr. mentioned, Dr. Raja Ramachandran, my colleague in PGI Chandigarh, he looks at remission rate and looks at the PLA2R at 3 months and redoses at 3 months to see it. But we haven't got any strong literature there, but there are clinicians who are using a 3-month mark to redose with rituximab.
So is there anything that the monitoring the rituximab dose by looking at the CD20 antibody levels like that?
So there are observational study where they actually give 1 dose of rituximab and instead of giving 2 doses, and then monitoring B cell and redosing based on B cell, whether there's a repopulation of the B cell. So it is there are literature there from observational study, and they have shown some promising results from that, sir.
Anyone? Dr. Girish, you want to ask?
No, small. Now, with this new antigens being identified for membranous, is it practical, financially feasible, and does it make any difference in the overall management we feel for every patient of membranous?
Yeah.
Where PLA is either positive, then the things are okay. If it's negative, do we screen for all these antigens and then? Yeah.
It's a philosophical question, Dr. Girish. I agree with you. In my center, we've just managed to get access to PLA2R antibody. So all these antigens is still in theory. It's in the research world. I don't think it's still available in clinical practice. I think it boils down to our clinical acumen, and I think good old proteinuria and renal function still are our best friends in managing these patients. So And clinical acumen is the most important thing. These antigens are a long way to go before they come for clinical practice.
This point is very important, although you said, Dr. Girish was saying the cost factor is there. But as Dr. Bhadran also discussed, in the long term, if you think distinguishing between primary and secondary membranes is very, very important. Although 70% yield in positive membrane, primary membranes is there with thrombus and PLA2R antibodies, but still, it always helps in determining the levels, the moderate, mild, moderate, and severe, how to treat and where to treat along with the GFRs. We should try to get it done in maximum number of cases. But I think there are a lot of questions. Probably we cannot go long. We can. Thank you, Dr. Bhadran, for that nice talk. We can have question later. Thank you so much.
Thank you, sir.
Thank you, sirs. May I request the chairperson to kindly honor our speaker, Dr. BhadranBose. May I request Dr. Cherian to kindly hand over a memento to the chairpersons, please?